Hey everyone, welcome back to Dietitians and Nutrition Support. Today we have Andrew Evans and Heather Stanner joining us to talk a little bit about lipid emulsions and some things to consider in terms of infection rates. When we see these different types of lipid emulsions such as fish oil or olive oil compared to our typical soy oil-based lipid emulsions, we're seeing that there may be some differences in health outcomes for our patients. And so today, Andrew and Heather are going to talk through a few different investigations that look to compare different types of lipids and the infection outcomes and hospital length of stay that they saw that may have been different or may have been the same. So let's pop over to Andrew and Heather and they'll give you all the details.
I'm Andrew Evans. I'm a dietitian out of Minneapolis, Minnesota. I've been a dietitian for a little more than 5 years. And I guess my work-related interests are anything GI-related and then lipids and TPN.
Hi, I'm Heather Stanner. I am a corporate dietitian and infusion nutrition specialist for Clarence CVS Specialty Infusion Services. I have been a dietitian for about 15 years, and I have an interest in nutrition support, specifically home care. I've worked in a variety of settings in the past, and I'm particularly interested in lipids and the evolving market and availability of lipids.
Our topic is a supplemental fish oil and olive oil based lipid emulsions and infectious outcomes in a hospitalized setting. This slide just represents all the different types of lipids that are available in the US. As you can tell, there are 4. The first one is a 100% soybean based. That is the most common. But then each generation after the first, they add another type of lipid to it, or I guess another type of fatty acid. The second generation, they added a 50% MCT. The third generation added olive oil, and then the fourth generation added fish oil, to where there are 2 types of lipids in the fourth generation. There's a mixed oil and a fish oil. The mixed oil has MCT, LCT, it has olive oil and fish oil, and then the last one, fish oil, being it's only 100% fish oil. So in terms of what type of fatty acids, whether it's omega-6 and omega-3, they do have a different response on the gene expression of a person's at the membrane level. In omega-6, it will activate a gene that's a pro-inflammatory gene. And if you want to know what it is the nuclear transcription factor kappa beta. It writes many codes for a lot of different pro-inflammatory properties and characteristics. When you look at omega-3, it reduces the amount of omega-6 that is relayed in the body's response to infection or a bout of inflammation. And it does so through a couple of different mechanisms. One, it reduces the pro-inflammatory gene from responding. It also controls the intensity and the duration of a person's bout with inflammation. It also makes lipid mediators, and there are 3 main types: resolvin, marsin, and protectin. And so those just help get to its, I guess, more of a neutral state of inflammation, or just a neutral state. So now we need to discuss what is an eicosanoid. It is a 20-carbon fatty acid that regulates many of the biological functions in the person's body in terms of host defense, vasoactivity, and reproduction. So they are not stored in a cell. They are rather a respondent to a bout of inflammation or to an external stimulus. They are also involved in the intensity and the duration of inflammation. And so the kind of eicosanoid that the body makes, it does dictate what kind of inflammation response a person's body responds to. For instance, if you have a higher dose of omega-6 in a person's inflammatory cell membrane, that is going to cause a more heightened inflammatory response, because it produces many of the eicosanoids, or many of the pro-inflammatory leukotrienes, thromboxanes, and prostaglandins. Whereas the omega-3, when that is present, that is going to reduce the omega-6 presence at the inflammatory cell membrane. And when especially EPA is going to produce the odd series prostaglandins, leukotrienes, and thromboxanes. And in doing so, it has a much less inflammation response. It can either be considered anti-inflammatory or even less pro-inflammatory. So now moving on to the clinical cases that involve patients who have received supplemental fish oil. The first one is a study that was by Jiang in 2016. And all patients either had an underlying diagnosis of metastatic liver cancer, or intrahepatic bile duct cathesis. So all patients underwent a liver resection. There were two groups, those that received the soybean and those that received soybean plus fish oil. And the rest of the information is on the slide provided below. So now moving on to the results. Those that received the fish oil, they had a reduction in infections. Although it did not meet the burden of statistical significance, it did show a trend towards reduction. And then they also assessed and examined the overall complications. There was a huge difference in the number of complications between the two, whereas the fish oil group had 15, and then the group that received a soybean, they had 26. The next was hospital length of stay, and those that received fish oil on average had 2 days less than those that received the soybean oil. So next, on the next study, it's by Jiang in 2009. And so this was a randomized clinical trial that looked at 203 patients who had underlying diagnosis of GI or colon cancer who underwent surgery. The two groups were broken down to those that received fish oil plus soybean, and then the other group just received a soybean oil. Patients were given TPN for a week, and they pretty much had the exact same nutrition prescription as each other. The results in this study were that the total infections, although again it did not meet the burden of statistical significance, it did show again a trend toward reduction, whereas those in the fish oil had 4 and those in the soybean had 12. Next, they looked at a hospital length of stay, and it also, those that received fish oil on average had 2 days less in the hospital, those that received a soybean oil. So in this study, they also looked at the cost of patients that was related to nutrition cost, and then the cost that was non-nutrition related. In the patients that received a soybean, they had a lower cost in the nutrition than those in the fish oil. Then, well, the opposite is true when they looked at the non-nutrition cost. In those that received a soybean, well, they had a higher cost. In those in the fish oil, it was a lower cost. When the researchers, and so when they added at the end the cost of nutrition and non-nutrition costs, they were pretty much identical. So at least in this study of 203 patients, it shows that patients who received a supplemental fish oil, that their overall cost, it really was no difference. And it could be because that those who had fish or who received fish oil, they were not in the hospital as long, and then also they had quite fewer number of infection episodes as well. Okay, and so now on to my third study. It was by Wang, that was done in 2009 out of China. So this is a randomized clinical trial pilot study that looked at 56 patients who had severe acute pancreatitis. There were 28 patients in both groups, the fish oil and the soybean. They were given TPN for only 5 days. They did not report hospital length of stay, but rather they focused on the number of infection complications. And those who received a soybean, they had 3 higher than those that received the fish oil, and it did not meet the burden of statistical significance. But again, it did show a trend towards reduction. And again, it could be because of just how the body responds at the gene level. And so now the last study is by Badia-Tahull. It was done in 2010. It was a 900-bed teaching hospital in Spain. And so all the 27 patients underwent elective major GI surgery. So this was the first study of its kind that assessed was there any benefit between olive oil versus fish oil. In many other studies, they compared either olive oil and fish oil, but it was compared to a soybean. And so this was a new type of study. And so what they looked at in terms of outcomes, they looked at the number of infections. So as you can tell on the screen, there were 11 infections in the olive oil compared to only 3 in the fish oil group. So that did reach the burden of statistical significance. And so what is not on this slide is the occurrence of the sepsis occurrence. So there were a total of 5 in the olive oil and 1 in the fish oil. So when they looked at, or when they added or assessed the number of infections and the sepsis occurrence, it was a high percentage of patients. That could be because these patients underwent major GI surgery and they were really ill at the time of surgery as well. And then they also looked at the hospital length of stay, and there really wasn't much of a difference between the 2 groups, whereas they averaged 15 days in the olive oil group and 16 in the fish oil. And then there was 2 limitations in the study. The first one was the small sample size, and then the second one is the lack of inflammatory and immune markers. The main focus of the study was not that, but it was rather the clinical outcomes that I just mentioned.
Okay, thanks so much, Andrew, for reviewing those studies related to supplemental fish oil compared to either soybean oil-based ILE or olive oil-based ILE in that last study. And I'm going to take it from here and review 3 studies that we identified using olive oil-based ILE compared to soy oil-based ILE in hospitalized non-critically ill patients. So the first study that I wanted to review, comparing olive oil-based ILE to soy oil-based ILE, was a retrospective quasi-experimental study by Araujo et al., and this was done back in 2018. And it actually involved a chart review of surgical and medical patients who received PN for at least 7 days. So they looked at patients that received olive oil-based ILE compared to soy oil-based ILE in 96 and 110 patients. And again, this was not a randomized prospective trial. This was looking back at patients that had received these lipids for at least a week. And they were also receiving treatment at different time periods over a period of 3 years. They looked at the dosing of lipid as well as other macronutrients, and they found that the lipid dose was significantly higher in the olive oil group. However, this group, although they did receive more lipids and actually less dextrose, these differences were adjusted for in the outcome analyses. So what they found by looking back at these records is that the olive oil group had significantly more infections. They experienced 35 infections versus those in the soy oil group at 24 infections, and this was statistically significant. They did not find any difference in duration of hospital length of stay between the groups. And again, limitations with this study mostly is that it was a retrospective chart review rather than a prospective randomized trial. So the second study is was a large prospective randomized multi-center study in China. It involved 18 medical centers, including surgical and medical patients who received PN between 5 and 14 days. And in this study, the patients were allowed an oral diet or enteral nutrition on day 6, and macronutrient content in the PN was adjusted to accommodate for the oral or enteral intake. This was a larger study, 226 patients in the olive oil-based ILE group versus 232 in the soy oil group. They found that there were significantly more total infections in the soy oil group at 26 versus 8 in the olive oil group, and total patients infected were greater in the soy oil group at 24 versus 8 patients having infections in the olive oil group. And both of these were statistically significant findings. And there were more lung infections when looking at types of infections in the soy oil group versus the olive oil group. And similar to the previous study, no differences were found in hospital length of stay between the 2 groups. And the last study comparing olive oil-based ILE to soy oil-based ILE and infectious outcomes was a study in 2011 by ONAR. This was a Turkish study. It was a prospective randomized trial in oncology patients who underwent surgery. They received parenteral nutrition for at least 7 days. This was a small study. There were only 10 patients in each group, and they both received 0.75 grams of lipid per kilo per day. This study was unique to the other studies in that it only looked at catheter infection rate, and what they found was that the catheter infection rate was the same between 2 groups, as 2 patients in each group experienced a catheter infection. And in this study, data on hospital length of stay were not reported. So to sum up all of the studies that Andrew spoke about earlier and the 3 studies that I just reviewed today, we wanted to provide a snapshot of the study design, sample size, and some other characteristics. Most of the studies we talked about today were prospective randomized trials. The only exception was the study in the olive oil-based ILE group versus soy oil group, and that was a retrospective chart review. But other than that, they had stronger study designs. Sample size varied anywhere from 20-some patients in both types of studies, all the way up to 458 patients in that large multi-center trial in olive oil-based ILEs. Dosing varied, but was somewhat similar. In the fish oil studies, the dosing of ILE was 0.88 to 1.2 gram per kilo per day. Again, that's not just including the fish oil, but it's including the supplemental fish oil and the base or comparative ILE, being soy oil-based ILE or olive oil-based ILE. And in the olive oil studies, the dosing ranged from 0.75 to 0.8 gram per kilo per day. And in all of these studies, the infectious outcomes varied per study. So no 2 studies were alike in the types of infections that they captured. In terms of results of infectious outcomes, we also saw varying results. In the fish oil studies, all 4 of the studies did show a reduction in infectious outcomes in the group that received supplemental fish oil. However, only one of these studies showed a statistically significant decrease in infections. However, the study authors noted that many of these studies may have been underpowered to detect statistical significance. In terms of the olive oil studies, we saw varying results in terms of infectious outcomes. When looking at results of hospital length of stay and combining all the studies, we also saw varying study results. And in terms of hospital length of stay, that's something that's difficult to compare to different hospitals, facilities, as there are different medical and surgical practices at each unique facility. So how do we apply any of this information into clinical practice, or are we able to do so? First, I just wanted to mention that ILEs are approved for use as a calorie source only. So when you're looking at prescribing information for the various ILEs, you won't see a decrease in infections as an indication for use. The only exception to an ILE that does have a specific treatment purpose is supplemental fish oil in pediatric patients to treat parenteral nutrition-associated cholestasis, or PNAC. However, the other ILE types do not have an approved use for decrease in infections. However, based on the results of these studies, that may be something that it does require more studies, but there could be more information in the future. When looking at different studies and related to ILE type and infectious outcomes, we always want to pay attention to the ILE dosing and whether or not the patient received enteral nutrition or took in any sort of oral intake during the study. And also looking at the characteristics of the sample, if it was done in a specific patient population, such as in a patient with acute pancreatitis or patients that received elective surgery. So the types of patients, it's always important to look at that to see if it's comparable to your patient population. And then, as I mentioned earlier, the small sample size in a lot of these studies indicate that the studies may not have been adequately powered to detect statistically significant results. And as always, it's important to evaluate the clinical relevance of any study results, even if they are statistically significant. So overall, the ILE type may play a role in increasing or decreasing inflammation and infection in hospitalized patients, particularly supplemental fish oil and olive oil-based ILEs. And as Andrew mentioned earlier, the mechanisms of eicosanoid production, gene expression, and resolvin production based on the type of fatty acid present may play a role in all of this. And although some of study results are promising in using alternative ILEs and decreasing infections in hospitalized non-critically ill patients, the relationship is not yet fully understood, and we do need more studies to solidify the benefit of decrease in infection and any potential types of ILEs. Thanks so much for joining us today. We hope you learned a little bit more about potential benefits of various ILEs.